So the next presenter will be, as Mike gets busy answering some of the questions that came through, will be a case of a very complex displaced sacral fracture with anterior ring injuries as well from Dr. Chip Routt. So I think this will be a very interesting case. So bring it forward some great points. So Chip, we'll turn it over to you.
Hi, Steve. Thank you all. Greetings from Hurricane Hannah, and we have pandemic and we have hurricane today in Houston. So hopefully I'll have power for the rest of my 12-minute assignment here. I've been asked to go through an unstable pelvic ring, and I hope you'll be able to easily identify the diagnosis on the patient that I'll show you. And I think the initial management has gone over so well. And our patient is a little bit different than all the initial management patients you've seen so far. She's going to be hemodynamically stable throughout her initial management, and she's never really even going to have much tachycardia. So we don't have to worry so much about that. More specifically, we're going to just focus on the imaging, and we're going to try to use the imaging details to help us interpret what we would do as far as the decision making. And I'll try to focus mostly on decision making and the preoperative planning, and then I'll carry you through for about a 7-year follow-up now with a 4-year radiographic follow-up. So I'll just present you with a 24-year-old female who rides a moped in order to save money. She's putting herself through college. She's in the last year of college. Her mother's a nurse down the street at an ICU. Just a very bright young female, got hit by a car. And you can see very easily that her symphysis pubis is completely disrupted. The left ramus is fractured and completely displaced. And then you can easily identify, I think, her right transforaminal sacral fracture and the displacement of her right hemipelvis cranially on this film. And then it almost looks like an obturator oblique of the right side. So you get a good idea of the violence of injury of this right hemipelvis. And I'll just tell you the left hemipelvis is going to be okay. So the injury details present very quickly to us on the plain film, and I think it's always good to cheat and look at the plain film first off. Her past medical history is irrelevant. She's on no medications, and in reality, that's a radiographically obvious unstable ring, and so we don't have to go pushing on this or feeling this for mechanical instability. It's obvious on the x-rays. So still, though, perhaps a little bit of a volume expanding, and so you may want to consider doing some things to her. If you look at her 3Ds, you can see on the inlet surface rendered image, she's got a nice anterior iliac, sacral border, and you can see the deformity and displacement through the sacral area, as well as the symphysis pubis and the left ramus fracture. The Z shape of the ramus is a good thing. You can also see on the outlet reformatted image that the fracture may leak up into or extend into the 5th lumbar vertebra area. Look at the comminution around 1 o'clock, 2 o'clock on the S1 tunnel exit area, the foramen. You can see some comminution there as well. And again, you can see the deformity of the right hemipelvis. The oblique views we don't use very much, but in this instance, it's a great look at the surface of the fracture plane. And you can see the two surfaces very well. You know, if you were a clot remover and a reducer, you'd really want to get right into that plane of the sacrum to put those two back together. And then I like the posterior view a lot, just to look at the cortical details of the surface of the dorsal sacrum to see exactly how comminuted it might be. If I choose to maybe do an open reduction on this, where would I set a clamp? Should I dock it in the ilium on the right side through a drill hole and then down around the spinous process of the caudal sacrum? Could I put a clamp on the caudal exit point of the sacral fracture? How cranial can I get with my dissection, and how deep does that dissection get? What are the interdigitations of the fracture? How relevant will they be to me to help me identify an accurate reduction, whether I'm doing it closed or open? And then again, the posterior oblique view, just to look down the plane of the surfaces. I love these views to help me see the fracture surfaces that I might need to get into, and then imagine what would be in that area besides just the hematoma. The axial images will show you the dysmorphism of her upper sacral segment, that little bit of comminution at the nerve root tunnel you can see on the upper left there. The second axial image just shows the patency of S2 and the anatomy of S2, or the second sacral segment. And then the parasymphyseal film there, the axial image shows the symphysis and the ramus. And then again, you can see on the sagittal, she's got a pretty good inclination of her upper sacrum, so you can plan her inlet view like we talked about 2 weeks ago. So I don't really think she needs a bunch of other evaluations. She's hemodynamically stable. She's neurologically normal. We certainly want to do a detailed neurological exam. And then I think for her, this may be a great patient for traction to try to help improve the reduction of this. And then we mostly just have to figure out what we want to do and when we want to do it. And luckily for us and for her, she's never really been sick. Her soft tissues are in great shape. She doesn't have any abrasions. She doesn't have any identifiable ecchymoses or contusions. If you look back to her axial images, her soft tissues don't even look like they have soft tissue degloving injuries. You can see on the upper left axial image the contrast in the vessels. The hematoma in the area of the sacral fracture doesn't seem to have much contrast in it. So again, not really a difficult physiological patient to take care of, but maybe a structural problem for a rebuilding. In the operating room, I think it's always good just to see what the paralysis or what the anesthesia does to the patient. And here's just some plain or images, an inlet and an outlet image of the sacrum with her just in 15 pounds of traction supine. And I think in 2013, the way I handle this would be a lot different than the way I would handle it in 2020, because in 2020, we have devices now in the operating room for the last 4 or 5 years where we can do with the fluoroscopy advanced imaging to see the value or the alignment of this using closed techniques. And we can get an idea if we want to use closed reduction techniques and percutaneous fixation, or if we want to proceed to open reduction. I thought this was a pretty good closed reduction, but again, I was limited by the fluoroscopy that I had in 2013. So we have to decide, are we going to do an ORIF for the anterior pelvis first and then just closed reduction to sacrum? A lot of people like that. They say it's minimally invasive. It avoids the soft tissue complications of posterior pelvic ring, and that's okay. Maybe closed reduction of the sacrum and anterior X-fix, that would be even simpler to do, but maybe not as structurally sound. The X-fix is not so mechanically efficient. And then maybe closed reduction of the sacrum, ramus and the sacrum, and then plus or minus an X-fix. Or we could do prone operation. We could turn her prone and do ORIF of the sacrum first, with or without lumbar pelvic, because remember we had the fracture extending up into the L5 area. Or prone ORIF and then turn her over and do supine, anterior X-fix, or ORIF. So a lot of different options. We chose to do prone. We left her in traction, although this is an unstable fracture. I don't think you necessarily have to use traction at all. I don't know its value because it's an unstable fracture. We did a direct dorsal approach so we could see that fracture plane, see the cortical dorsal edges, clean them, reduce it, and then clamp it. And if you practice with the imaging, you can start to sort of ghost in these modeling so you can use what you may see during the surgery while you're doing the dorsal approach. And we did a direct dorsal approach. Once we were able to see this and remove the hematoma and the local tissue, we were able to clamp, and we did use a caudal tenaculum clamp first just to get the length at the area of that exit. That's a really broad surface, densely corticated surface to put our first medium tenaculum clamp, and then a subsequent clamp a little bit more proximally. And then we used a summary clamp in the operating room just to get both vectors so we could restore the length and also the reduction, and we could summarize that with just an oblique clamp like you see there in the operating room. And then we went ahead and used iliosacral screws to accommodate the pathways. The fracture is clamped, and so we used fully threaded screws. At the cranial site, or the upper sacral segment, we put 2 individual screws. And then at the second sacral segment, we used a transsacral screw, and then turned her over, did a low midline approach. And I tried to do a ramus screw on her. We did an open reduction of her ramus and clamped it, but she's a little bit curved for a straight screw. So we used an intrapelvic type of plate and then plated up her symphysis. You can see her symphyseal area, the bone in that area is kind of frail. Someone earlier asked, well, do you use 2 plates a lot? We don't usually use 2 plates because the mechanical advantages in the lab weren't really realized in the people. And then you can see here when we combine plates, sometimes there's not a lot of room along the symphysis to dock 2 plates. You could have also made the intrapelvic plate just go to the opposite side as well. You can contour the plate for that. And I think y'all have seen some examples of that. So we thought that this was really good for her pelvic component, but again, not so much for her spine component. The person that helps me with spinal pelvic or lumbopelvic fixation was actually at the American Academy meeting during this time, and he came back 2 days later and then went ahead and fortified her fixation construct to include this. He does percutaneous lumbopelvic, and so this was he didn't have to reopen our wound or anything like that. It would have been a whole lot better to have had someone in town and coordinate that through the first operation, but it wasn't possible. With percutaneous lumbopelvic, they can slip these in under fluoroscopy and do the work that's necessary. Dr. Stover was already talking about. Postoperatively, we allowed her to have full weight bearing, on her uninjured side on the left side, and then we allowed her protected weight bearing on her right side, and just did some isometrics. The isometrics and the stretching and the light aerobic is, I think, important for the first 6 weeks, and then after that we let her sort of cut loose. This was her last film at 4 years. She had graduated college, full-time employment, did every activity she wanted, refused her hardware. She didn't have symptoms related to this. And then she plans on having children. She's married and plans on having a family. Of course, no obstetrician in North America is going to allow her to have a spontaneous vaginal delivery. But that's the extent of this injury, and the reason we chose what we did was, when I opened this fracture, at the time we did the open reduction, it didn't have this much displacement at all. This fracture was maybe 4 millimeters displaced with her asleep and prone, and when we went to put this clamp on. And so the amount of displacement that we had visible to us on the fluoroscopy views intraoperatively was pretty real. And it's as close as it looks there, but still probably 4 to 5 millimeters off. And I think the open reduction helped us to improve the contact, helps us to improve the reduction, helps us to get a better stable fixation, also to restore those conduits of fixation like we talked about, so the screws are safer and give us less deformity. So thank you very much for your attention. I hope that this patient's example has brought up some good reflection points for you and discussion points for later on.
That's a great case. I'm sure we could spend the next hour and a half talking about this one if we wanted to. So many different treatment choices, but could you, there were several questions about nerve roots, and in the last case we saw where there was a laminectomy done to decompress the nerve roots. Could you talk about
Sure.
about that for this case, and the nerve roots, and whether you think anything else needs to be done there?
Yeah, so her nerve roots were all normal. So she didn't have any nerve problems at all. And so all we're doing is reconstituting the tubes. One of the reasons I like open reduction for transforaminal sacral fractures, if there's identifiable debris that's accessible, we can just fetch that debris during the course of the exposure. If it's way anterior, like hers was way anterior and up in the, like that's why I sit up at 1 o'clock to 2 o'clock on the anterior cranial aspect of the tunnel exit point. And with her being neurologically normal, with the open reduction, it makes those tubes go back together. That's the beauty of open reduction. The tubes are coming back together anatomically. And so I don't see any reason to dissect out nerves or try to look. You can see them in the wound sometimes, but I don't think there's any reason to go after nerves or things like that. And I believe open reduction is a really good thing because it puts the tubes back together, or those
So
nerve
the open reduction basically does the decompression for you, almost, basically.
Yeah, it just puts the nerves back into it, puts the tunnels back together appropriately.
And then Chip, maybe one last question before we get Dr. Carnacher on for this next case. Can you, this may be an unfair question. If it's going to take 30 minutes, you may have you type it in, but I don't want to ask you something that's too difficult to answer briefly. But can you give us an idea when you think an open reduction for a sacral fracture is necessary?
When a closed reduction,
in your practice,
when a closed reduction is insufficient. So if you, and with the advanced imaging we have right now, we can assess that really well in the operating room. So if you have a reduction that's totally insufficient with closed techniques, then you just need an open reduction. People try all these different manipulations with beds and tools and all these outriggers, and they just need a knife. You need a knife and some retractors and some clamps. So some fractures, you just shouldn't work for hours trying to get a closed reduction. You just open them, clamp them, put them back together.
So you start out supine and go through some traction and maybe some maneuvers to see if it reduces, and if it doesn't, then you would turn them prone and do an open reduction?
Yes, I would have accepted this closed reduction if she had any type of issues, if I couldn't turn her prone, whatever it is. Some people, I can't, terrible abrasions, terrible soft tissues, things like that, I might have gone for closed reduction, but this is just an insufficient closed reduction.
Great. I'm sure, Chip, there's going to be there are a lot of questions coming in. So if you'll take a look at the question and answer session, I appreciate you can answer some of the questions. Great case, and thanks for going through that.